Hello and welcome to Anesthesia Bootcamp. Please like, share, and subscribe to our channel. Continuing with the cardiovascular reflex series, let's discuss the chemoreceptor reflex. The primary function of the chemoreflex is to regulate the respiratory activity in response to change in levels of oxygen, CO2, and the pH. But it has cardiovascular implications too. So, what are the chemoreceptors? In general, a chemoreceptor is an extension of the nervous system equipped to detect changes in the chemical environment of the cell. The chemoreceptors participating in the chemoreflex can be classified on the basis of their anatomical location into the central chemoreceptors and the peripheral ones. The central chemoreceptors are located on the ventrolateral surface of the medulla. Their main function is to sense the pH of the CSF via the acid sensing ion channels. So, they are mainly sensitive to the pH. These chemoreceptors are obviously sensitive to hypoxia. Also, they are activated indirectly by CO2, which crosses the blood-brain barrier and is converted to bicarbonate to ultimately decrease the CSF pH. With prolonged hypercapnia, these receptors desensitize due to bicarbonate redistribution from the CSF and its increased renal excretion. The central chemoreceptors are mainly involved in the respiratory part of the chemoreflex. The peripheral chemoreceptors are one of the organs with the greatest blood supply, thanks to the dense capillary network which ensures accurate sampling of the blood and a prompt response. The chemoreceptors consist of two types of cells, the type 1 glomus cells and the type 2 glia-like cells. The type 1 transduce the signals from the blood and transmit impulses through the nerves. And the type 2 form the support and also act as stem cells. The type 1 cells carry a huge spectrum of neurotransmitters in the vesicles related to the transduction process, which are absent in the type 2s. In prolonged hypoxia scenarios, the type 2 cells proliferate into type 1 cells. Quantitatively, the types 1 and 2 in a ratio of 4:1. The peripheral chemoreceptors exist in clusters termed as aortic bodies located at the aortic arch and the carotid bodies at the bifurcation of the common carotid arteries. These locations are strategically important, with each set providing unique information about the oxygenation status. The aortic body monitors the oxygen concentration near the heart, and the carotid bodies provide information regarding the arterial oxygen levels. The aortic bodies are more sensitive to the total oxygen content, whereas the carotid bodies are more sensitive to the oxygen partial pressure. The difference between the two can be seen in this pop-up box. The total oxygen content that influences the aortic bodies being the sum of the dissolved oxygen in the plasma and the hemoglobin bound form. The dissolved form of oxygen is responsible for the partial pressure and holds more effect on the carotid bodies. Now let's look at the reflex pathways. The peripheral chemoreceptors are more sensitive to oxygen levels, and hence hypoxia acts as a major activator, though hypercapnia and acidosis contribute too. Like the baroreceptors, signal conduction from carotid bodies occurs through the glossopharyngeal and that from the aortic bodies via the vagus. Also, these signals are again processed in the nucleus tractus solitarius. The NTS via the nucleus ambiguous and the dorsal vagal nucleus increases vagal activity, resulting in bradycardia and coronary vasodilation. The NTS, through its effects on the interactions between the caudal and rostral ventrolateral medulla, manages to increase the sympathetic activity. This results in hypertension due to increases in the SVR. The effect of chemoreflex on the heart rate is quite interesting. From the flowchart described, It's evident that the primary effect of the reflex is tachycardia, but I think this needs more clarification. Also, tachycardia can be seen in some cases secondary to various coexisting factors. I'm sure you must be thinking what exactly happens to the heart rate in practice. So now a big question mark looms over the heart rate. Let's try to wipe that off. Decreased oxygen availability, CO2 buildup, and acidosis are powerful stimulants for sympathetic activity. And from our experience, we know that during a fight or flight response, there is a rise in the blood pressure and the heart rate. So, why don't we see a bradycardia? The triggering of chemoreflex causes activation of the NTS. The parasympathetic activation by the NTS directly causes bradycardia. The NTS also increases sympathetic outflow, resulting in hypertension. The volume status of the subject being normal, the hypertension triggers the baroreceptor reflex, again causing bradycardia. In real life practice, I am sure we all have come across this fall in heart rate. In our regular practice, we have all come across difficult intubations where we are unable to ventilate and oxygenate the patient, as in the dreaded CVCI situations. Another scenario when we are suctioning the tracheostomy tube of a patient on ventilatory support. I am sure you can recall the change in the pitch of the pulse beat of the monitor, indicating a fall in the saturation followed by progressive slowing of the beat of the heart rate. As you are struggling with the job at hand, I am sure you can recall the blaring of the alarms, adding to your anxiety. Some patients exhibit tachycardia instead, especially the spontaneously breathing ones. The hypoxia, hypercapnia also activate the central chemoreceptors. These are responsible for increasing the respiratory efforts. The associated rise in the negative intrathoracic pressure increases the venous return. The increased preload causes tachycardia via the Bainbridge reflex. Also, the increased respiratory efforts cause an increase in the pulmonary stretch, which in turn triggers the Herring-Brewer reflex, resulting in a rise in the heart rate. So, this is everything about the cardiac part of the chemoreflex. Please leave your comments and suggestions below. Thank you.